We are dissecting a highly significant research paper published in May 2026.
In the Acta Scientific Medical Sciences Journal, right?
That's the one. The title is quite a mouthful. It's Making Tacit Surgical Knowledge Explicit, a structured reflective protocol for teaching local perforator flap reconstruction supported by AI-generated imagery. Yeah, and it comes to us from a team of highly specialized plastic and reconstructive surgeons working out of the Department of Aesthetic and Plastic Surgery at CIHSR in Nagaland, India.
Okay, let's unpack this,
Yeah.
because we really need to translate that academic title into the actual mission of this deep dive.
Absolutely.
These surgeons, they haven't just published another standard case study. They have engineered a protocol that attempts to solve this massive silent crisis happening in operating rooms worldwide.
A crisis of knowledge transfer.
Right. So we are going to examine their system. We're going to test it against their 19-case series of incredibly complex facial cancer reconstructions, which, by the way, resulted in an unheard of 100% success rate.
Which is staggering.
It really is. We're going to get down to the millimeter level of how human tissue is manipulated, and then we're going to look at how they used artificial intelligence to solve a massive ethical roadblock in medical education.
To really appreciate the weight of what the CIHSR protocol is trying to accomplish, I think we have to establish the historical bedrock of surgical education first.
Right? How do surgeons actually learn to do this stuff?
Well, for centuries, the entire discipline of surgery has been built on the apprenticeship model. The famous maxim is, see one, do one, teach one.
Though in modern reconstructive surgery, that's probably a bit of an understatement, right?
Oh, completely. Today, it's more like see 500, assist on 200, and slowly do a few under intense microscopic supervision.
It's a master-apprentice dynamic. You stand at the operating table next to the attending surgeon for literally years.
You hold the retractors, you suction the blood.
Yeah, and you watch their hands. You are basically trying to absorb their tacit knowledge through sheer proximity, like osmosis.
And, that model produces brilliant surgeons, don't get me wrong, but it contains a critical vulnerability, which the authors of this paper highlight almost immediately.
What's the vulnerability?
Well, the master surgeon holding the scalpel possesses an absolute ocean of tacit knowledge. They know, on a cellular level, why they are making a specific incision, or why they are leaving a bridge of tissue exactly 2 centimeters wide.
Right, they're processing a million things at once.
Exactly. They are processing tissue elasticity, blood flow, 3-dimensional geometry, all simultaneously. But they rarely, if ever, articulate that internal calculus out loud.
Problem there is, if the master surgeon doesn't narrate the why, the apprentice standing next to them only ever sees the what.
Precisely. The trainee sees the final incision, but not the 50 invisible mental checks that determined its location.
Wow.
And the authors point out that relying on this silent osmosis, it's becoming increasingly dangerous in modern medicine.
Because the environment is changing.
Exactly. The apprenticeship model assumes that the trainee has unlimited time to just stand next to the master, and that the master will miraculously encounter every possible surgical variation while the trainee happens to be in the room.
Which is definitely not how hospitals work anymore.
Neither is true anymore. Today, residents have strictly capped working hours to prevent fatigue. Patient volumes are highly centralized, and attending surgeons are just overwhelmed with administrative burdens.
Meaning, if a junior surgeon isn't physically present in the OR on a random Tuesday when the attending handles a highly unusual facial tumor, that specific piece of tacit knowledge is just gone. Inaccessible to them forever.
It is entirely lost. And when an entire generation of master reconstructive surgeons retires, their internal libraries of spatial reasoning and tissue management they retire with them.
That's terrifying, actually.
It is. The literature is surprisingly bare when it comes to the actual how of surgical decision-making. What Mathis and Nahai did in 1981 was map out the human vascular system in relation to muscles.
Okay.
They proved that muscles don't just have random blood supplies, they follow very strict anatomical patterns. They categorized every muscle in the body into 5 types based on where the dominant arteries and veins entered them.
Oh, wow. So once you knew the map, you could safely disconnect a muscle, knowing exactly which blood vessel you needed to keep intact to keep it alive.
Exactly. It was a complete watershed moment.
Okay, so they essentially created the master plumbing schematic for the human body.
That's a perfect way to put it, yes. And then, the paper moves forward to 1989, to Koshima's introduction of the perforator flap concept, which honestly changed the paradigm entirely.
I want to make sure I'm visualizing a perforator flap correctly because this is so central to the whole paper.
We have experienced 4 decades of explosive advancement in the capability of reconstructive surgery, from muscle flaps to these incredibly delicate perforator flaps. But the authors argue that the documentation of how to actually execute them, the tactile feedback, the visual cues, the specific geometry required to keep a 1 millimeter blood vessel flowing, that documentation has not kept pace.
Because it's all tacit knowledge.
Exactly. Standard textbooks might give you a nice line drawing of a perforator, but they do not tell you how much tension that vessel can withstand before it snaps or clots.
I understand the frustration, I really do, but I have to push back a little here.
Sure.
We established that the cognitive load of surgery is immense, and that tacit knowledge is fundamentally resistant to language. So if it's so hard to articulate, maybe it shouldn't be articulated. And to write down the equivalent of a cello vibrato.
The authors of the CIHSR study would actually concede your point regarding the absolute necessity of physical practice. They are not claiming that their protocol replaces the operating room.
Okay, that's a relief.
Not at all. They explicitly state that hands-on, messy, real-world cases are the ultimate crucible for learning, how the parts relate to the whole. And at the very top of the pyramid are evaluating and creating.
Okay, so how did the surgeons adapt this?
The authors of this paper structured their 5-step surgical protocol to force the attending surgeon to walk up that exact cognitive pyramid regarding the surgery they just finished performing.
Oh, so it's a forced progression of thought. What is step 1 of the protocol then?
Step 1 maps to the base of the pyramid. Understand the anatomical concept.
What does that entail?
The surgeon must explicitly document the biological foundation of the operation. What was the specific vascular basis of the flap? Where exactly were the perforator vessels located? What were the tissue dynamics of the donor site?
It essentially establishes the fundamental physics and anatomy of the board that we're playing on.
Exactly.
That makes perfect sense. It's defining the materials. Then we move up a level to step 2. Apply nuanced problem solving.
Right. This is where the surgeon has to justify their strategy. They can't just write down, I used a cheek flap. They have to answer why.
Why this specific flap for this specific patient?
Yes. And in facial reconstruction, this is incredibly complex because they have to document their reasoning regarding tissue availability, color match, and what they call aesthetic subunits.
We should definitely elaborate on aesthetic subunits because it dictates so much of facial surgery.
It really does. The human face is not perceived by the eye as just one continuous sheet of flesh. It is viewed as a topographical map divided by natural borders.
Like the nasolabial folds or the contour of the cheekbones.
Or the shadows of the eye sockets. If a surgeon places a scar across one of those natural borders, the human eye immediately detects the asymmetry. It looks unnatural.
So step 2 forces the surgeon to explicitly write down how they navigated those aesthetic borders when they designed the tissue movement.
Precisely. They've documented the anatomy, and they've justified the strategy.
Okay, so what happens in step 3?
Step 3 is the core extraction of the tacit knowledge. Analyze the technique. This is where the surgeon must break down the continuous flow of the operation into highly granular, reproducible steps.
Like down to the millimeter.
Absolutely. We are talking about documenting the exact angles of the incision lines. They have to articulate the specific microscopic tissue planes they dissected through.
Oh, like did they cut above the muscle fascia or below it?
Exactly. What was the exact width of the tissue pedicle carrying the blood supply?
Step 3 forces them into system 2 thinking. Slow, deliberate, analytical. They have to literally reverse engineer their own instincts.
That is a vital observation. It forces them out of that operative flow state and into an objective analysis of their own mechanics.
Wow.
Which leads seamlessly into step 4, evaluate outcomes.
So looking at the results.
But this isn't just about looking at the patient before they leave the hospital. This step requires documenting the functional and aesthetic results over time. Was the patient satisfied? Did the tissue settle correctly?
Yeah, what if something goes wrong?
Crucially, if there was a complication, venous congestion, partial tissue loss, infection, the surgeon must rigorously document how it occurred and the specific interventions they used to manage it.
So the failures are treated as data just as much as the successes.
Yes, exactly.
And finally, step 5 is the top of Bloom's pyramid.
Create a reproducible lesson. This is the synthesis. The surgeon takes the raw data from the anatomy, the strategy, the microtechnique, and the outcome, and distills it into a finalized, highly structured teaching record.
Okay,
And the paper moves immediately from this theoretical framework to cold, hard clinical proof.
because they actually tested it.
Yes, the CIHSR department didn't just propose this protocol. They applied it retrospectively to a consecutive case series to demonstrate exactly what kind of knowledge it extracts and what kind of outcomes it supports.
And this data set is fascinating. The series covers patients who underwent facial reconstruction following the surgical excision of basal cell carcinoma, or BCC, between April 2023 and July 2025.
Right.
Let's look closely at these patients because the demographics dictate the extreme difficulty of the surgery.
So basal cell carcinoma is the most common form of skin cancer. While it rarely metastasizes or spreads to distant organs, it is highly locally destructive.
Meaning it just eats away at whatever's around it.
Yes, it behaves like a slow-moving fire, eroding skin, cartilage, and bone if left untreated. The only curative treatment is complete surgical excision.
Which leaves a defect, a hole, that must be reconstructed.
Exactly.
So the authors compiled a final cohort of 19 patients. There were 12 females with a mean age of 67.5 years and 7 males with a mean age of 70.
That's right.
Now, I noticed in the paper they originally evaluated 21 patients. Why did they exclude those other two?
The exclusions demonstrate the rigor of their methodology, honestly. They excluded one patient who presented with squamous cell carcinoma, which is a different, more aggressive histology that requires different surgical margins and potentially lymph node management.
Okay, so that would taint the data pool.
Exactly. They excluded another patient with neurofibromatosis type 1, which is a genetic disorder that fundamentally alters the nature of the skin and nerves, which would definitely skew the reconstructive data.
Makes sense.
And they excluded patients whose cancer was so advanced it required massive multidisciplinary resections involving neurosurgeons or ENT specialists. They wanted a pure, isolated data set focused entirely on local perforator flap reconstructions for BCC.
So we have 19 elderly patients, all requiring facial tissue manipulation. The challenge of operating on a 70-year-old's face is vastly different than operating on a 20-year-old, isn't it?
Oh, completely. The skin has lost elasticity, the blood vessels are much more fragile, and they often have underlying comorbidities.
Like hypertension or diabetes.
Right, which heavily compromise wound healing. When you combine fragile tissue with the aesthetic demands of the human face we discussed earlier, the need to maintain eyelid function, nostril symmetry, lip competence, the margin for error is essentially zero.
Which is what makes the primary outcome of this study so staggering.
It really is.
Across all 19 of these highly complex facial reconstructions, utilizing various delicate perforator flaps, the surgical team achieved a 100% flap survival rate.
That is an unbelievable statistic in reconstructive surgery. 19 out of 19 flaps survived completely.
There were 0 cases of total flap failure.
0. There was no partial necrosis either, which is a common occurrence where the furthest tip of the transposed tissue dies because the microblood supply just can't reach it.
Wow.
There were no post-operative infections and no long-term contour deformities.
And the patients were happy?
Incredibly. Furthermore, paper reports that at the 6-month follow-up, when all the swelling has subsided and the final scar has matured, patient satisfaction scores exceeded a 7 on the Likert scale for every single individual.
So they were overwhelmingly happy with both how their faces functioned and how they looked.
Yes.
Now, a skeptical listener might look at that 100% success rate and say, well, the protocol didn't do the surgery. The surgeons are just incredibly skilled.
Which they undoubtedly are.
Right. But here's where it gets really interesting. The CIHSR protocol is the engine that allows us to see why they are so skilled. The paper uses the 5-step framework to basically open up the hood on these surgeries. It doesn't just present the 100% survival rate as a boast. It utilizes 2 specific, highly detailed case studies to show us the exact tacit knowledge that secured that perfect outcome.
Let's dissect those case studies because this is where the abstract theory of tacit knowledge becomes visceral reality.
Yes, let's get into the weeds.
So surgeons utilized a variety of advanced techniques across the 19 cases. Nasolabial perforator flaps, cheek perforator flaps, including the keystone perforator island, flap glabellar flaps for the thick tissue between the eyebrows,
What else?
VY advancements, and paramedian forehead flaps.
Before we hit the specific cases, translate VY advancement for me. We've talked about moving tissue sideways, but what is a VY?
It is a beautiful piece of geometrical tissue engineering. Imagine a circular hole on the cheek.
Okay, I'm picturing it.
Instead of cutting a patch from somewhere else and moving it over, the surgeon cuts a V-shaped pattern into the skin immediately adjacent to the hole. They dissect the tissue underneath the V, leaving the central blood supply intact.
So it's still attached from the bottom.
Yes. They then push that V-shaped wedge of tissue forward to fill the hole.
Oh, wow.
When they stitch the gap left behind by the V, they pull the edges together in a straight line, forming the stem of a Y.
So by suturing a V into a Y, you physically recruit horizontal width and convert it into forward length.
All while maintaining the local blood supply.
That's brilliant.
Yeah.
It's essentially using origami on human skin to close the gap without pulling everything too tight.
It really is like origami.
Okay, let's look at lesson 1 from the paper, which utilizes a different geometrical approach. The keystone perforator nasolabial flap.
Right. So the protocol begins with the clinical scenario. The patient is a 69-year-old female presenting with a 2 by 2.5 centimeter ulcerated basal cell carcinoma located on her left alar region.
The alar region is the flared, fleshy side of the nostril, right? A 2.5 centimeter tumor there is massive. It's essentially the size of a large coin sitting directly on the curvature of the nose.
So it's a very difficult spot.
And to cure the cancer, the surgeons have to perform a wide local excision, taking an additional 5 millimeters of healthy tissue in every direction just to ensure the margins are clear of microscopic cancer cells.
Exactly.
Once the tumor is removed, they are left with a gaping, full-thickness defect on one of the most visible, complex curves of the human face.
And this is where step 2 of the protocol outlines the problem-solving logic.
What was the logic here?
The tacit knowledge extracted highlights why standard linear closures or skin grafts just fail in this area. If you simply pull the edges of the hole together and stitch it, the tension will distort the nostril, pulling it upward and exposing the inside of the nose.
Which looks terrible and functions poorly.
Right. And if you use a skin graft, taking a shaving of skin from the thigh, it will look like a pale patch on a textured nose, and it will likely contract and cause a deformity anyway.
So what did they do?
The surgeons documented that they chose the nasolabial fold, the deep crease that runs from the side of the nose down to the corner of the mouth, as the donor site.
Oh, because it's immediately adjacent, meaning the skin color and texture match perfectly?
Yes, and because you can hide the resulting scar directly inside that natural laugh line.
That's incredibly smart.
Step 1, the anatomy, dictates that this tissue is robustly supplied by the perforating branches of the facial artery, which run deep beneath that crease. They designed a keystone flap, meaning the tissue is cut in a specific arch-like shape resembling the keystone of a Roman bridge.
Okay, I see.
The entire perimeter of the flap is incised through the skin, isolating it like an island. The only thing attaching it to the body is the tiny perforator vessel feeding it from underneath.
It's like a hot air balloon tethered to the ground by a single gas line.
That is an excellent visualization, but the absolute critical piece of tacit knowledge, the detail that ensures the flap actually survives, is extracted in step 3, analyzing the technique.
What did they find in step 3?
The attending surgeon explicitly noted that the dimensions of the keystone flap must be designed to slightly exceed the dimensions of the defect it is meant to fill.
Wait, let's test that logic. If I have a hole in drywall, I cut a patch exactly the same size as the hole. If the flap is bigger than the hole, won't it bunch up and look terrible? Why intentionally oversize it?
Because living tissue is not drywall. It is a pressurized hydraulic system.
Oh, right.
If you cut the flap to the exact millimeter size of the defect, you will have to stretch it slightly to place the sutures. That stretching creates mechanical tension across the surface of the flap.
And tension is the enemy of blood flow.
Exactly. But it's not the arteries you have to worry about initially.
It's not.
No, arteries have thick muscular walls. They can handle a bit of pressure. The real danger is the venous system. Veins are thin, floppy, low-pressure vessels responsible for draining the deoxygenated blood out of the tissue.
So if there's tension...
If you place the flap under even a...
I know enough about oncology to know that the word recurrent drastically changes the mathematical odds of success.
Recurrent tumors are treacherous. This cancer grew back after an incomplete excision at a different medical center 6 months prior.
So the area is already messed up.
Exactly.
Yeah.
The surgical bed is no longer pristine anatomy. It is filled with dense, unpredictable scar tissue. The local microscopic blood vessels have already been severed or rearranged by the first surgery.
To achieve clearance this time, the surgical margins have to be extremely wide and deep, I imagine.
Yes. Step 2, the problem solving, reveals that the resulting hole on the bridge of the nose was simply too massive to be covered by the surrounding tissue on the cheeks or the nasolabial folds.
The local supply was tapped out.
The surgeons had to recruit tissue from a completely different aesthetic zone. They chose the paramedian forehead flap, which is considered the heavy artillery of facial reconstruction.
Step 1 defines the anatomy, and this is fundamentally different from the perforator flaps we just discussed, isn't it?
Yes, this is an axial flap. It relies on a major, named blood vessel, the supratrochlear artery, which exits the skull at the inner edge of the eyebrow and runs vertically straight up the forehead to the hairline.
Let me make sure I'm visualizing this architecture correctly, because it sounds intense.
It is very intense.
They cut a long vertical rectangle of skin and muscle right out of the center of the patient's forehead. But they leave the bottom of that rectangle attached to the eyebrow, because that's where the supratrochlear artery enters the tissue.
Correct.
Then they peel that entire rectangle off the skull, pivot it 180 degrees downward, and sew the top edge of it over the hole on the nose.
That is precisely what occurs. It leaves the patient with a thick bridge of tissue spanning from their eyebrow down to their nose, carrying the blood supply.
Over their eye.
Yes, the patient lives with this bridge, often called a pedicle, blocking their vision for about 3 weeks.
Wow. 3 weeks.
During that time, the skin sewn onto the nose slowly grows new, microscopic blood vessel connections with the surrounding nasal tissue. Once those new connections are established, the surgeon performs a second operation to sever the bridge at the eyebrow and stitch everything flat.
It is an incredible feat of biological engineering, but the execution sounds terrifying.
It requires immense precision.
The technical analysis in Step 3 of the CIHSR protocol is where things get aggressively dense. The surgeon documented the exact plane of elevation required as they peeled that forehead tissue downward.
The explicit documentation here is vital. The surgeon notes that they must begin the dissection at the top of the forehead in the loose areolar tissue plane beneath the frontalis muscle.
Okay, so that's relatively shallow.
Yes, a relatively superficial plane. However, as they dissect downward toward the eyebrow, approaching the critical blood vessels, the Tacit technical sequence mandates that they transition the dissection significantly deeper into a superiostele plane.
Translates superiostele for me. The periosteum is the absolute bottom layer, right?
Correct. The periosteum is the dense, fibrous membrane that tightly adheres to the surface of the skull bone itself. A superiostele dissection means the surgeon is essentially scraping the tissue directly off the bare bone.
Why do they have to dive that deep as they get closer to the eyebrow? Why not stay in the same upper layer the whole way down?
Because of the three-dimensional trajectory of the supratrochlear artery. It exits the skull deep near the bone and then travels upwards and outwards toward the skin surface as it goes up the forehead.
Oh, I see.
If the surgeon stays in the superficial plane as they dissect downward, they will accidentally slice right through the main artery as it dives deep toward its origin, completely destroying the blood supply for the entire flap.
That would be a disaster. So the protocol explicitly maps the depth change required to protect the vessel.
Exactly.
But then we get to the most critical number in the entire paper, the absolute unyielding geometric rule. The surgeon notes exactly where they make this transition to the bone and exactly how wide they cut the base of the flap at the eyebrow.
The protocol states that the transition to the superiostele plane must occur exactly 2 centimeters above the suborbital rim, the bony ridge above the eye.
And the width.
Crucially, it documents that across their series of 9 forehead flaps, the width of the pedicle base at the eyebrow must be maintained at approximately 2 centimeters.
2 centimeters. We need to focus on this number because it represents the ultimate compromise of reconstructive surgery.
It really does.
Why 2 centimeters? Why not 4 centimeters? To make absolutely sure you include the artery and all the veins.
Because every surgical decision is a trade-off. If you make the base 4 centimeters wide, you guarantee excellent blood flow. But remember, you have just removed a massive vertical strip of tissue from the patient's forehead.
You have to close that hole.
You have to physically pull the skin of the forehead together and stitch it shut. If the base of the flap at the eyebrow is 4 centimeters wide, the forehead skin simply won't stretch enough to close the gap. The tension would be insurmountable. The AHSR paper does something remarkable here.
What's that?
It doesn't just present the 2-centimeter rule. It uses the Step 4 outcome evaluation to rigorously document what happens when you violate the rule.
In one of their 9 paramedian forehead flap cases, the surgeon noted that they created a pedicle base that was approximately 1.5 centimeters wide instead of the mandated 2 centimeters.
A deviation of 5 millimeters, half a centimeter.
And the result of that tiny microscopic deviation was early venous congestion. The flap began to fail on postoperative days 3 and 4.
We mentioned venous congestion earlier with the keystone flap, but in a massive forehead flap, it is a surgical emergency.
Right.
The supratrochlear artery at the center of the 1.5 centimeter pedicle was perfectly intact. It was vigorously pumping oxygenated blood down into the flap on the nose.
So the blood is going in.
But because the pedicle was cut half a centimeter too narrow, the delicate, low-pressure venous network surrounding the artery was severed. The blood had no way to drain back out. The tissue turns violently purple, swells with toxic deoxygenated blood, and begins to die.
It's a terrifying scenario for a surgeon. Fortunately, the Step 4 evaluation notes that this congestion was managed conservatively.
Yes, they likely removed a few strategic sutures to physically release the trapped blood, and within a week, the new microvessels in the nose took over the drainage and the flap survived.
But the explicit teaching point extracted from this near failure is just invaluable.
It is. A standard textbook will just say, maintain a narrow pedicle to allow rotation. It leaves the interpretation completely up to the reader.
Which is dangerous.
Extremely. The CIHSR protocol forces the expert to write, the pedicle must be 2 centimeters. We attempted 1.5 centimeters and it induced critical venous congestion. The margin of error is less than 5 millimeters. Do not deviate.
That specific, hard-won, terrifying lesson is now explicitly available to every resident in that hospital.
That is the power of making tacit knowledge explicit. But as the authors formalize these geometric rules, the 2 centimeter pedicle, the keystone oversizing, they ran into a massive secondary problem.
Oh, what was that?
It is one thing to write down, cut a 2 centimeter base at the supraorbital rim. It is entirely another thing for a junior surgeon to visualize it. To teach surgical geometry effectively, you must be able to show it.
You need high-resolution imagery of the actual tissue plane.
This paper is focused entirely on local facial reconstruction.
The human face is our primary identifier. Every operative photograph of a nasolabial fold or a paramedian forehead flap inherently captures the patient's eyes, their mouth, the unique contours of their profile.
Right, and you can't just slap a little black sensor bar over their eyes if you are demonstrating a massive flap that literally bridges the forehead to the nose.
The geometry you need to show covers the entire face.
This creates an immense ethical and privacy paradox. In modern medical practice, patient confidentiality is paramount.
As it should be.
Distributing highly traumatic, graphic images of a patient's open facial wounds for global educational purposes requires intense, specific consent. Many patients, understandably, refuse.
Yeah, I wouldn't want my most vulnerable, disfiguring moments immortalized in a medical journal either.
Exactly. And beyond patient refusal, the authors note a very practical infrastructural limitation. Not every hospital, especially in developing regions or smaller tertiary centers, has a dedicated, secure medical photography department.
Oh, true. The legal and digital infrastructure required to securely store, anonymize, and distribute real patient photographs without violating HIPAA or international privacy laws, that is massively expensive and complicated.
So the surgeons at CIHSR were faced with a dilemma. They had successfully used their protocol to extract world-class, life-saving tacit knowledge.
Right, they couldn't show anyone how to do it.
Right. How could they visually communicate the intricate geometry of a keystone flap or the exact placement of a 2 centimeter pedicle without violating the privacy of the 19 patients who trusted them?
And the solution they utilized is what firmly anchors this paper in the year 2026.
It really is.
They turned to generative artificial intelligence. Specifically, the paper notes they used modern iterations of ChatGPT and Perplexity AI to generate synthetic visual representations of the operative findings in flap designs.
This is a profound shift in medical education. Instead of relying on a human medical illustrator, which is costly and slow, or risking a privacy breach with a real photo, they prompted these large language models to generate highly detailed anatomical diagrams of the surgeries.
Okay, I have to aggressively push back on this because this sounds incredibly risky.
I completely understand why you'd say that.
Large language models are essentially predictive text and pixel engines. They don't actually understand biology. We have all seen AI generate images of humans with 6 fingers or 3 arms or bicycles with no pedals.
Oh, we all have, yes.
If I am a junior surgeon trying to learn the exact trajectory of the supratrochlear artery, why would I ever trust a diagram generated by an algorithm that frequently hallucinates physical reality?
Your skepticism is entirely warranted, and it touches on the core debate surrounding AI in medicine right now. How did the AI know where to put the 2-centimeter pedicle?
Right. How did it know?
It didn't. The AI is completely blind to medical reality. The accuracy of the synthetic image is entirely dependent on the extreme specificity of the prompt engineered by the expert surgeon.
So the surgeons aren't just typing, hey, draw a forehead flap. They're essentially programming the AI with the data extracted from the 5-step protocol.
Exactly. They feed the explicit knowledge into the machine. They type, generate a schematic illustration of a human face. Map the supratrochlear artery emerging 2 centimeters from the midline. Superimpose a vertical rectangular flap extending from the hairline to the supraorbital rim with the pedicle base exactly 2 centimeters wide.
Oh, well.
The AI acts purely as a rendering engine for the expert's highly specific geometric coordinates.
But even with a perfect prompt, the paper is very careful to define the limits of these images, aren't they?
Yeah.
They aren't trying to generate photorealistic, bloody surgical fields.
No, and the authors are very humble about this limitation. They explicitly state that these AI-generated images are adequate for teaching the concepts, the design, and the geometry of the flaps.
They're essentially high-tech blueprints.
Yes, they brilliantly illustrate the lines on the map, where the cuts go, how the tissue pivots.
They show the math of the surgery.
Yes. But the paper clarifies that for teaching the full complexity of operative surgery, the actual texture of human fat, the specific color change of venous congestion, the physical resistance of the periosteum against the scalpel, real cases, and real human tissue remain absolutely essential.
Right. AI cannot synthesize the tactile reality of the operating room.
Not at all.
So the AI is a supplemental bridge. It solves the privacy paradox perfectly. It allows these surgeons in Nagaland to publish the precise geometry of a complex facial reconstruction, distributing that knowledge globally without ever compromising the identity or the dignity of the actual 69-year-old woman who underwent the procedure.
Exactly. The AI provides the safe, ethical blueprint, but the resident still has to go to the OR to learn how to swing the hammer. It really is an incredible piece of work.
We have covered an immense amount of ground today, moving from the abstract philosophy of human cognition down to the microscopic reality of a collapsing human vein and out to the ethical frontiers of artificial intelligence.
A true deep dive.
So what does this all mean?
If we synthesize the totality of the CIHSR paper, it demonstrates that tacit knowledge is not some magical, inaccessible aura possessed only by master surgeons.
It's just unformatted data.
Exactly. It is highly granular data that hasn't been formatted yet. By implementing a rigid 5-step reflective framework based on Bloom's taxonomy, these authors proved that we can force experts to externalize that data.
And they proved it works.
They validated the system with a 100% success rate in 19 highly demanding facial cancer reconstructions. And by utilizing AI to visualize the geometry, they created a globally scalable, privacy-preserving model for elite medical education.
It is a blueprint for ensuring that the genius of a master surgeon doesn't just evaporate the day they retire. And I want you, the listener, to pull this concept out of the operating room and apply it to your own life.
That's a great takeaway.
Whatever your profession is, whether you are writing code, managing a supply chain, or teaching a classroom, what is your tacit knowledge? What is your personal version of the 2-centimeter pedicle rule?
Everyone has one.
What is that tiny, incredibly specific, hard-won detail that you execute purely on instinct every single day that would save a junior colleague weeks of agonizing trial and error if you just took the time to write it down? Maybe it's time you tried forcing yourself out of the flow of performance mode and into the friction of reflection mode.
It is a profound and often humbling exercise to try and decode your own expertise.
It truly is. And as we wrap up this deep dive, I want to leave you with one final thought to mull over, building on where this technology is inevitably heading.
Oh, this should be interesting.
The CIHSR surgeons are using AI in 2026 to generate retrospective blueprints.
Yeah.
But if AI language models can already render complex geometry based on prompts, how long until the AI is simply integrated directly into the operating room?
Real-time analysis.
Exactly. Imagine an AI system utilizing overhead cameras and sensors, tracking the surgeon's scalpel in real time. The AI maps the tissue planes, calculates the tension on the flap based on the stretch of the skin, and automatically logs that the pedicle was cut at exactly 1.9 centimeters.
Oh, wow.
If the master surgeon is too exhausted to find the words to explain their tacit knowledge, will the AI eventually become the ultimate silent apprentice watching, calculating, and automatically writing the textbook for the next generation as the surgery happens? Think about it. We'll catch you on the next deep dive.